Thank you very much, Brad. Before we start, I'd like to introduce our new Managing Director, Scott Dorman. Scott has a great distinguished career in entertainment, tech, startups, and philanthropy. So we're really happy to have Scott at the center, and he's going to kick off this panel on digital health access.
Great. Thank you so much, Dr. Saxon, and good morning to everyone. Just want to provide a very, very brief overview to provide some context for the panel. As all of you know, the smartphone has become the new platform for healthcare, and that will continue as a trend throughout the future going forward. For that reason, we created, as Dr. Saxon mentioned, the virtual care clinic and announced that last year at the conference. Excuse me. The model of the virtual care clinic, which we'll be talking a lot more today, is to be able to deliver qualified content, virtual physicians, and a lot of the pieces that you'll, again, see today through the virtual care clinic. As also Dr. Saxon said, we are passionately committed to leaving no one behind in our society when it comes to healthcare. Unfortunately, lower-income people and the underserved tend to go off their cell plans for understandable reasons, always financial. And so this year we're creating and announcing the Digital Health Access Initiative to address that very, very deep problem in our society. Again, we'll be talking about that more today. But that's the platform through which we'll be able to provide cell phones and plans to the underserved so they can also have important access to health care. And with that, I think we should go ahead and proceed with the panel.
Great. So we have three people in an excellent position to speak to the issues that surround provisioning a population, particularly the underserved, with the necessary devices and data plans needed to access the solutions that we're all creating. Hal, I'd like to start with you. Can you just talk about what you do, a little bit why you do it, and the problem of delivering health care to the population that you service?
Okay, so thanks, Leslie, for inviting me to talk to all these folks. I guess I want to start actually with some context. It seems to me that right now we're in one of the most transformational times in medicine and healthcare. And the reason it's transforming fundamentally is because the drivers underlying healthcare financing have changed. In 1965, we had the establishment of CMS and a model for federally funded fee-for-service healthcare. And we also had the growth of NIH, which sponsored a lot of research with lots of large indirect cost structure that went to the universities. That allowed us to evolve to a place where our current model of healthcare is largely driven by fee-for-service, volume-oriented healthcare. You do more, you get paid more. The second thing we're driven by is quaternary care healthcare. How can we do the most expensive, most fanciest? The drivers have changed. Society realizes that the costs of healthcare cannot continue to go up. We can't go much beyond 20% of GDP, and we're about 17.5% right now. What are the new drivers? The new drivers are from healthcare financing. We need to cap spending, and managed care is looking like the model that we're going to be moving forward towards. So we're going to be getting paid to take care of populations of patients and provide them with high quality care. And nobody's going to care about how much we do or how fancy it is. In terms of the university and research, funding there is not drying up, but it's sort of stalled out in terms of discovering molecules. Society wants us to take all of this work we've done over the last 50 years of discovery and translate it into real live care of real live people. And one of the things I'm going to say is, it is really terrific to think about access. But as somebody who's the chief medical officer of the LA County Department of Health Services, where we're responsible for the traditionally underserved, I actually don't want this to look like a handout. I want this to look like, first, let me paint a picture of what we're doing, what our challenge is. So the LA County Department of Health Services We run 4 hospitals, 19 clinics, and have 175 community health partners. We have a panel of about 500,000 patients. They're historically poor people, people on expanded Medicaid, and people who are uninsurable. Those are the folks we take care of. We also take care of the largest emergency departments and trauma centers. We have a budget of about $5 billion. We have 20,000 employees. When our team came here 5.5 years ago, we came to a system that did not have a unique patient identifier. Imagine taking care of a system this big, 10 million residents in the county of Los Angeles, 4 hospitals, and you can't differentiate the patients because you don't have a unique identifier. Now, it's even worse than that. Within the first 2 weeks of my getting here as chief medical officer, one of the finance people came to me and said, Dr. Yee, can you help me get the national provider identifiers for the doctors? They didn't even know who was taking care of patients in this system. This is the sort of challenge that we have. And what we need to do is to disrupt, because if all we were to do is try to become, catch up with, 2016 healthcare at Kaiser, Group Health, Geisinger Clinic, we're never going to catch up. And so I guess what I would submit is the reason that we're an important system of care, the reason I retired from UCSF and took this opportunity was this is an amazing model of testing things for the United States of America. If you can fix it for a system like this, you might have something for the rest of America. So that's our challenge in the county. We need to disrupt. I mean disruption, disruptive innovation, as Clay Christensen has described, right? We need to bring things from other industries that solve problems sometimes that the doctors and the healthcare executives didn't even know existed. I don't have a lot of time, so I'm going to leave you with 2 cautions. The work that you folks are doing, the 1% of you who actually succeed, are going to be the ones who have to, I believe, listen to these 2 cautions. First, don't do what most people in the industry do, which is try to replicate what is currently being done virtually or digitally. Because if you do, you will probably fail. What you want to do is develop tools that help us think differently about healthcare. The goal is not to say, what are we doing in clinic, follow people around and say, okay, how do we do that digitally? The goal is to say, if we have these tools, how do we imagine healthcare will look differently? The second caution I have is, and this is a real challenge, and it's been a real challenge for most of health information technology historically. It's not about the technology. It's not about the platform. It's not about the application. It's about how do people use these things. So I will stop there. Thank you very much.
Thank you, Hal. Rachelle,
Wow.
you've been an FCC Commissioner. How do we do this?
Well, I'm guilty of being a serial regulator, both at the federal level and the state level, but don't hold it against me. I do believe in innovation, and I do think that the people in this room could resolve some of the access and equality issues that the doctor just outlined. I have a PowerPoint, but I think I'm going to digress. I just would like to make it available to everybody online, right? They'll be able to see it. Okay. So I'm working on this project because I believe in the result. In 1996, when the Telecom Act passed, there was this belief by Vice President Al Gore and by the 5 FCC commissioners that technology and telecommunications and the nascent internet at that time, quaintly called the information superhighway, was going to help people with their health issues around the world. And 20 years later, I'm sitting here at this conference, and I can see that this indeed is happening. But I do think we have a tremendous amount of policy and regulation that is old-fashioned, that is getting in the way of innovation. And that's what I'm here trying to figure out what to do. Now, very briefly, Dr. Saxon went over some of the statistics having to do with the poor and broadband access. And the bottom line is I've looked at all the stats. We gather them yearly here in California, for example, and 84% of California households have internet, but 14% of them only have a smartphone. And you can't do everything on a smartphone. You can't do your research for your term paper if you're a student. You can't properly go look for your health information on a smartphone. You can't look for a job and apply online on a smartphone with a resume. So there's a lot of things you can't do. So what I'm working on as a personal and a professional thing is how do we get low-cost broadband access to the poor so that they can have access to all the tools that the rest of us have. And that's today's problem that I'd like to try to solve. So 4 big things that need to happen to do that. 1, we have to actually get broadband infrastructure to everybody. Here in California, for example, the rural areas, Central Valley, Imperial, up far in the north, crappy internet, right? Drops all the time, dial-up, it's terrible. So the FCC and the PUC both have infrastructure programs for grants. But to be very honest, these are private providers, former telcos and cable guys and wireless guys, and they're not going to build unless there's a case for them to get a return on investment. So even with these grants from the feds and the state, very limited, almost gone, they still can't get it to everybody. So what are we going to do about that? 2, affordability. I've been working very heavily for 3 years trying to get low-income plans to the poor. And finally, after 3 years of militating, the FCC has finally announced a new Lifeline-type program for broadband for the first time, fast internet. And it's going to be phased in over 6 years, but all it gives you is a $9 and $25 credit from the government to the provider to discount your broadband for a low-income person. The good news is the eligibility is extremely broad, so most poor people will qualify. But having said that, as you probably know, a typical broadband plan is $40 to $65 a month. So if your discount is $9.25, that still puts it out of the reach of the typical low-income person to get. So this is still a big problem. There were a bunch of cable and telco mergers, and I've been working with a nonprofit, and we intervened in these cases for the mergers at the FCC and the PUC, and we managed to wrest, and that's what it was, we wrested it out of the corporate companies, 4 low-income broadband plans for California. You'll see it on my slides, but AT&T, Frontier, Charter, and Comcast now have essentially $10 to $15 low-income broadband plans for people. But these are limited, but it took a lot of effort, but we did it. Final thing that you should know is FCC does have an E-rate program that provides discounts to rural healthcare providers and public hospitals. It's a program that I worked on very heavily, but that's only for the providers, not for the consumers. So it helps a little bit. Other issues that need fixing, probably the biggest one is the compensation for doctors for doing digital health. As you know, that's been a big flog. All the rules vary by states. There's cross-licensing issues that still remain unresolved. A number of people are working at this. Progress is terribly slow. If there was one thing I asked this group to do, many of you have very powerful lobbyists in Washington and in California. Please, please, please get your lobbyists working hard to resolve these compensation issues. That's tremendously huge. Finally, I would say that security is the last important regulatory issue. I'm not going to delve into FDA because we have a FDA person here and I can't even pretend to go to those issues. But I will tell you on security, nobody is going to use these devices unless they feel secure. Let's look at these self-driving cars, for example. Great idea in theory, but are you going to trust it, on a freeway going 70 miles an hour with nobody at the wheel? So you got to get over that consumer fear. So likewise, with your devices, you would darn well better be building in advance, all the security, anti-hacker, blah, 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 you know the list, because people aren't going to trust it with their health information. It's very personal. So we have a lot of challenges here in policy arena. I would urge you to not just look at your technology, but to think about the policy, because you could build it, but the regulators may not let you use it. Thank you.
Thank you. So Jill, I want to reframe things a little bit. This is a problem of the indigent, and, you know, we're lucky enough to work with Hal, who's like, hey, the one thing our people have is cell phones, so go blow it up. But when we go to the, and do it better. When we go to the private side, though, and where there's Medicare payment, and we're dealing with companies that are trying to provision tablets, or we developed a solution with our heart failure doctors here to develop a way to manage very complicated heart pump patients with an app on an iPhone. We need an iPhone right now. And so we figure we've got to provision about 70 people in the hospital and about another 70 just to do this study in 20 patients to create this digital ecosystem of care. Why does everyone in my hospital, including compliance, legal, want to run for the hills when I run in and talk about the study that I've gotten through the IRB and I can't get the phones paid for? That nurse practitioners aren't going to go out and buy a $600 phone and a 2-year data plan just to be able to check stuff. You service these types of clients. How are we going to fix this?
Right, so I think that the other speakers spoke very well about the fact that the law has not really caught up with where we are in the market and what we need to do and where we need to go, certainly in the future. One of the, I think, biggest impediments that providers deal with there are really two sort of frameworks. I mean, everyone talks about privacy and security and HIPAA, and of course there are a lot of issues around data transfer and keeping that secure and private. But the two other issues that I think are now coming more to the forefront are really reimbursement and the rules around reimbursement, as well as restrictions around giving beneficiaries for these federal payment programs any kind of inducement. And so when I take each of those, around the reimbursement issue, it's not just that providers don't want to provide these things because they're not going to get paid. That might be some of the issue, but a huge part of the issue is that when providers take care of a patient, they've entered into a contract with a particular payer for that patient, and that payment agreement, whether it's your Medicare enrollment or whether it's a contract with a commercial plan, restricts and provides rules around what can be provided for that patient and for how much money. One of the biggest barriers, actually, for providers that participate in the Medicare program, as well as Medicaid, is that they can't discern what's a covered service and what's not. And so when they go to try to provide something that hasn't been envisioned yet for one of these patients, they can't tell how they should bill for it, if they should even bill for it. And there's also rules against providing things to these patients for free. So it becomes almost like the providers become totally frozen because they can't figure out if they're violating the law by providing something for free, and they also can't figure out how to bill for it. So if you're deep in this world of Medicare billing, you understand that there are codes for each type of diagnoses, there's codes for each type of treatment. If there's not a code for something, you can't bill for it. Just the system doesn't recognize it. A lot of commercial payers use the exact same codes. So what happens when we bring new services online, if the code doesn't, if you're doing something that doesn't match a code, there's no way in the overall system to bill for the service. Everything kind of shuts down. So the only way you have a clear pass, and the easiest way to go to market on some of these pilots, is for patients who have pure cash pay, no payer. Or you've got a clear pass because you know automatically that the service clearly is not a covered service. But I'll give you a very specific example of where this gets hard. I worked with a health system that was trying to bring online home visits done by physicians and PAs supported by a mobile app similar to Uber. You could dial up and order a physician to go wherever you are, to your office, to your home, what have you. Well, in the world right now of healthcare, there's two types of home visits. There's home health, which has a bunch of rules about how you qualify for home health services. But there's also a code under Medicare that says you can provide services to a patient in the home if they have a medically necessary reason that they can't physically make it to the office. Well, someone who wants a home visit for convenience doesn't fit within that scheme. And when you bill for a visit, you also have to place site of service. There's a special code for that. So all of a sudden, the system totally breaks down because you can't bill, there's no code for home visit without medically necessary reason to go to the home, just convenience. And now no one knows how to bill for that service.
So that's just disheartening. In this where it's not fee-for-service and capitation, you see a lot of large healthcare systems developing venture funds and things like that. So healthcare providers themselves, can they legally disintermediate from Medicare payment and develop a separate system that they invest in, a digital system, or that can accommodate and allow for provisioning of things? And
Well, I mean, it's interesting because we're already starting to see that. So we're seeing it with pilots, we're seeing it with certain types of new systems where it's actually sad because the access, when you talk about access issues, the people that it's being made available to are people who are either cash pay or have commercial payer coverage, because those are the payer types that are willing to engage, and it's very, very hard to get CMS to engage on, is this a covered service or not, and how should we be providing it? We don't know if it's free, if we should do it. I mean, take telehealth. There's a lot of discussion right now amongst lawyers who work in the telehealth world about if you're providing telehealth service to a Medicare patient that doesn't fit within the framework of how it's reimbursed, it's not rural, it doesn't fit all those rules, can you actually provide the service to a Medicare patient? Is that permitted? Can you provide a Medicare patient an ABN and have them pay cash? That's not a clear
so
distinction.
do the Googles of the world have just a huge leg up against the Proteus Digital Health? They're trying to slug it out at the FDA and then actually sell this stuff into hospitals that can't even allow them to provide their,
I mean, what we're seeing is that hospitals that are really committed to try out this technology are starting with certain patient groups and pushing the envelope to expand that, and hoping that once there's broad adoption of this, that you will start seeing better guidance from the Fed, from CMS, on whether or not or how it can be provided to Medicare and Medicaid patients. That is, and I want to clarify too, because within the managed care world of Medicare and Medicaid, you do have a lot of flexibility because the rules are geared towards population health. You're allowed to give things to folks for free. There's much more, but in the Medicare Medicaid fee-for-service world, it was designed to provide very specific services, not provide anything for free for these folks, and so that's where it gets very difficult.
right? Hal?
I think this is so cool, this panel. If you heard what I said earlier, right? What I said is we have to not solve the current problems, we have to think about the future, and that the drivers underlying it are going to largely be a capitated managed care, not fee-for-service model. Now, that's speculation on my part. My two other speakers identify two of the things that they've been working on is how do you solve regulatory and fiscal financing challenges with regards to fee-for-service medicine? So the challenge all of us have, all of you have, is who are you going to gamble with? Are you going to be distracted by solving today's problem, providers who only want to take care of patients if they get paid a set fee for it? Or do you want to jump ahead and solve what I think American medicine has to move to, which is largely a managed care thing? Or am I wrong, and are you going to be risk averse, hedge your bets, and figure we've got at least 5, maybe 10 years of fee-for-service, and I'm going to keep fighting for that fee-for-service, and I'm going to pay my lobbyists to make sure we keep getting revenues, and the AMA is going to be successful, and pharmaceuticals are going to be successful. This is the fundamental question, and I guess I would submit that the truly disruptive companies are going to be the ones who guess right. You know, I left academics because my guess is working in a $5 billion capitated system allows me to start working with folks like you. Whoever wants to reach out to me, you can Google my email address, and we can solve the future of American medicine, not solve something that might be obsolete in 10 years.
Okay, we're at the crap table here at Body Computing, that we are gambling. We're right there with you. Questions? Anybody, raise your hand. We have mic people. Where are mic people?
Can I just make a point?
Yes.
I think in this world, it's so heavily regulated, it's so easy to just say no. And I think what you need to do is have the fortitude. Now, of course, there are things that are very illegal and criminal laws, but
Don't do those.
and you're dealing with a traditional health system that is extremely risk adverse, nonprofit, large BMFs that it's very easy to say no. And I think you have to be extremely bullish to say, tell me why. I need a yes. And let's figure out how we get a yes. And if maybe not for this many people, but maybe for this many people, and then how do we continue moving that? And I think that's the way you make headway in this market, because it's very easy to say, oh, we can't do that. There's lots of reasons.
Great. Hands, anybody? Dave?
It's coming.
Here it comes.
So the question I have for this panel is the Wayne Gretzky problem. Don't skate to the puck, because that's where all the big companies are, by the way. They're at the puck. They've got the puck. Skate to where the puck's going. I'm one of those pioneers. I don't take off my shirt anymore because the arrows in my back scars are really ugly. But that's the problem, is how are we going to get, enough lifeline, whether it's Proteus or AliveCore or whatever, to get to where the puck's going? Because the puck's going there, okay? There's no bundled payments from Medicare are going to push the risk to the provider. That's happening, and it's going to happen. MACRA passed the Senate 97-0, okay? Bipartisan. But we got to get there. For Cabbage and PCI, it's next year a pilot, and then after that, it's the issue of, can you survive to get to the puck? And how can regulators, policymakers help us get to where I think everyone thinks the puck's going, but we don't know when? 5 years, 10 years.
Right, and I guess as a physician, we hear this capitation thing, but the only thing capitation has done for us is take out innovation, at least federally paid innovation, added lots of penalties for doctors, made our lives more miserable, and told us to do better. And our patients, we never were able to provide a good service model to our patients unless we ruined our own personal lives and disrupted our systems to actually deliver care. Any of my patients would take a huge privacy risk if they didn't have to go through parking at USC. They would, I think, give away if they could just, so the idea that we can provide a service model and a high-touch level of health care to people, not to mention the problems of the indigent, to go to the racetrack of county hospitals pharmacy and take off from your $8 an hour job to that's just unrealistic. I wouldn't do that. I wouldn't go wait there. I forego my medicine. These things have to be better, provide service. People are going to demand them. I just don't know who's going to step up either.
Well, I think you got to look for the model, right? So what if I told you that I conceived of a model for doing electronic consultations between primary care providers and specialists? And we are now doing 18,000 of these a month in Los Angeles, and there's probably 3,000 or 4,000 a month being done in San Francisco. And the way I did it was not by not talking to council and not asking the state and the feds, and just doing it. And doing it because within a capitated health system, you can do all of these things, right? So, it's a gamble, but you hedge your bets by finding model systems that really, this is what, probably why I'm on the Clinical Translational Science Advisory Board for both USC and UCLA, because there's a lot of stuff that they can do with us to test innovation, intervention that they could never do with with Westwood or with Keck, because we are capitated and they're not.
I would like to say that I think politics is an area that could help this, and what really needs to happen is you need a champion. I would suggest that one of the presidential candidates who was active in healthcare could potentially be a champion who, from the White House level, could push on the federal agencies, and then that would set the model for the states. So I don't know, she's a little busy right now, but if things work out the way some of the polls indicate, you need to have a political champion. And I'm telling you right now, half the battles come from outdated regulations and definitions. And so I don't know, I know you guys are all heads down, you know, making your really cool devices and, you know, making sure people don't die, thank you. But, you know, policy, regulations, politics, this is how you get things done.
This is
Alex.
Alexander Grunewald here from Johnson & Johnson. So it seems to me this is a false dichotomy, because the reality is you cannot just give up doing one. I mean, we can't just say, you're a fee-for-service patient, sorry, I can't serve you. I only serve capitated patients, right? So what's going to have to happen, and what is happening, is that you have sort of an emergence where you plan for the future sort of bundled payments and so forth, and you develop towards that. And at the same time, you also try to work within the system as it is today. And probably the one place where you cannot do both is at the individual physician level. They cannot switch back and forth between patients. So I mean, if I was running a practice, which I'm not, I would probably say these are the bunch of physicians that are going to be fee-for-service oriented, and these are the bunch of physicians that are going to be bundled payment, and over time, I'm going to move more and more over, and that's a way to address this. And I guess does that make sense?
Yeah, I mean, it sounds like brain damage for people who don't work in hospitals, but for those of you who work in hospital systems, you understand that you have pools of patients that you're treating differently all the time based on who their payer is and how they're stratified within the system, because you can't actually treat everyone the same. So what you're talking about is just another layer for these big organizations to manage, to try to identify a specific pool of patients and say they can have access to these things, but not these things. So,
Right.
yeah, that's
Thank
what's
you.
happening.
Thanks for pointing that out. Michael?
Mike Bowdish, I'm one of the heart surgeons at USC. Kind of a simple question for Jill, that I wish maybe someone from CMS was here. I know we have FDA representation, or somebody from Optum or United Healthcare, or Dennis Irwin comes to mind. But the question is, I know dealing with the federal government a fair amount, I realize that it takes decades to centuries to have any change occur, especially as it relates to DRGs and payment and, you know, what we pay for what. But the private healthcare does tend to move a little bit quicker. So my question is, have we seen any movement on, you know, Optum Healthcare, United Healthcare, the blue plans in regards to virtual healthcare or remote monitoring, in creating codes that they will pay for people with, you know, PPO type insurance or advantage Medicare or something like that?
Yeah, actually, that we have, I have clients all the time that are having those discussions on a daily basis with the commercial plans. I think it's just a tough slog, because there's no real mechanism at some of these health plans for a health system to get together with it and say, hey, by the way, we're going to pilot a whole bunch of things, and so can we just have an ongoing dialogue about how the billing works for every single one we put online, so it ends up being a one-by-one conversation.
Because you'll hear about something Dr. Saxon, Fong, and I are working on. I think we're willing to do it without getting paid. I mean, what we're doing, I mean, we've kind of realized that for right now, we're not going to get a dime for it.
Right.
But there are patients, and we're going to see them in clinic, and we'll collect the fees for what we're supposed to based on the current rules and regulations. But I had heard some inklings, at least at the NIH, that there was some sort of evolvement in creating sort of virtual healthcare coding and things like this.
It's hard because there's no one really at the Fed whose point that you can call and say, help me with this, whereas the health plans, they are easier to engage. I want to be clear, though, that the issue is twofold. It's not just that health systems can't get paid for it, because a lot of them say, we don't care, we don't need to get paid. We actually think this is a benefit to patients and helps us for population health in the long run. The problem is that they're restricted from providing free services as well. So, for example, under the Medicare program, there are rules against kickbacks and what's referred to as beneficiary inducements, that a health system or a provider can't give something for free to a patient that might try to encourage them to later use clinical services from that provider. So interestingly enough, where we're seeing a lot of movement of providing...
Whoops, Mike, let's not talk anymore.
Where we're seeing more flexibility of providing some of these digital health solutions directly to patients is from health plans, because as long as you're not directing or trying to direct the care to a particular provider, you can provide things for free to people. So
So I just wanted to let the audience know what that means. That means that if we give an application that we think has a significant chance of avoiding stroke in a patient that had $1 million hospitalization from an implant and has a 60% chance of a readmission, and just by enhancing communication through an app, we can avoid a stroke based on a number that the patient has, and they know how much blood thinner to take, that it's illegal for us to do that. And you know, the savings of that person whose life we saved with that $1 million, who's going to die, and that life we saved, that we can't do that. And you know, what we're hoping, we're hoping to show that we can avoid that stroke with this method, but it's kind of unbelievable.
Yeah, I would just encourage, I mean, I don't even know where in the federal government to bring this up, but I mean, there's got to be somebody at CMS who's interested in this. And I know there are people at the NIH and NHLBI and NINDS and the research aspects that are very, very interested in this application of everything here to research technology. So there's got to be somebody on the fee side and the regulatory side who's interested in it.
It may be because Keck doesn't participate strongly in Medi-Cal, but CMS has been pretty supportive of these novel, innovative things through their 1115 Medicaid waiver. We will probably stand the County of LA to get tens of millions of dollars through, for example, electronic consultation. So there are spots of light.
Yeah, here again, in the managed care context, so lots of flexibility in managed care to underscore that issue. The OIG does recognize this. There are proposed regulations that came out now last year that haven't been finalized. The problem is that on the enforcement side from the OIG and Department of Justice, there is still so much, I would say, lack of knowledge of what's happening on the ground in the trenches, as well as just a deep-seated paranoia of opening it up too much, because what these rules were put in place for fundamentally was to combat fraud. So how do you draw that line? And any kind of change is going to be very incremental.
Wow. Have they gone after anybody yet on any of these issues and been successful, the DOJ?
No. See, this is the difficulty why providers are frozen, because you know, you've got a lot of emerging companies or younger companies that are saying, well, just push the envelope, just go for it. And you see any enforcement actions out there? And these big health systems are saying, hey, the penalties are so draconian. What do we get for doing that? You know?
Right. Great. I'm sorry. Yes.
One of the things that's been a little bit discouraging to me is as I read information about how many providers, how many physicians are retiring because they're tired. They're tired of the regulations. They're tired of sorting through the EMR, all of the, you know, the increasing volume and so forth. And at the same time, I see more and more of my colleagues who are not taking insurance, and they're very proud of it. They're talking about how they're giving a higher level of service because they don't have to deal with the insurers anymore, or they're going into the fee-for-service areas, you know, more of the cosmetics and so forth. And it's been more concierge-type practices, and it's been a little discouraging because it seems like we're automatically defaulting into a two-tiered system. And are there any lessons that you would take from what you're seeing from Europe, from Asia, understanding the differences, obviously the regulatory differences and so forth, any lessons you would take from there that may be applicable to what we're doing that might help us to not just default into that breakdown?
Don't you think Europe is defaulted there? I mean, they have a whole private system as well for wealthy people.
I mean, essentially, they've got, you know, NHS. You've got the people who can't pay the out-of-pocket money, and then you've got, and in India, I go there all the time, and we're certainly seeing that, although we're having a 1950s type of insurance movement now in India where all the insurers are coming in. And I think they're doing a little bit of a better job using their technology for the broader poor population, trying to use mobile apps and so forth. But
Okay.
I mean, do you have any thoughts on this?
I mean, I'm part of working with a drug company on how to massively screen for AF, and I can tell you that in Europe, they're talking about how to bill for these screens, and they're talking about just charging the people who opt out of the state system because the state systems won't pay for it. So while they're a little precious about how everybody has health care, they really do have a way of, you know, implementing things in a separate for-pay system. That's so I'm not sure, but I think this was great. Too bad we're starting the day with a little Debbie Downer here, but we're gonna pump it up a lot because we're gonna see a lot of great things and beg for forgiveness, I guess. Yeah.
Thank you very much, Michael Berlin. Jill, you brought up a Pandora's box. What happens with those of us who are care providers and teachers of medical students regarding ethics. We have not a two-tier, we have a multi-tier system. And if we're teaching people in schools how to treat these patients, what do we do about their ethics? What do you do about telling people who can and cannot receive certain levels of care, can and cannot receive certain levels of information? And also, what's the medical legal liability for us as teachers and for the students in their futures with these problems?
I think you raise a good question. We have a lot of discussions about that with providers. What's interesting is I think from the regulation standpoint, they view a lot of what's happening in digital health as being a different modality of communication, but that there continues to be the analog way of doing things, which is just as good. So, that's a qualitative decision and really a clinical decision. And I think it puts clinicians in a difficult spot, because I've had lots of conversations with physicians who argue that the newer way of doing things is actually better, and they're extremely frustrated that they can't provide it to a whole host, especially Medicare patients, which tend to need some of those services more. And they're just restricted from doing that. And it's, you're violating the law, really, if you do certain things for that population.
But what becomes the defined standard of care when we're being medical legally evaluated? That's the huge Pandora's box that we really have to address, too.
I agree.
Right, unless we want to get a bunch of administratively minded people into medical school, which we don't, right? Anyway, thank you. This was great. And thank you for all your expertise and for considering this problem. Thanks for being here.
Thank you.
Thank you.